Good morning, my dear students. Today, the topic for discussion is antifungal drugs. Antifungal drugs, as the name suggests, are active against fungal infection of the body. It can either be over the skin, superficial or deep. Okay. So today we will discuss in detail about antifungal. Two classes. I will take this chapter in two classes. Okay. Coming to the introduction part, antifungals are drugs that are used to treat a fungal infection, which can be superficial or deep fungal infections. Superficial on the skin, deep means systemic infections. Mostly are associated with broad spectrum antibiotics, corticosteroids. Mostly associated with the use of broad spectrum antibiotics, corticosteroids, and immunosuppressants, and catheters, indwelling catheters, implants, and emergence of AIDS. All these conditions will lead to fungal infections in our body. It only after chronic use, not for a one time use or two time use. After chronic use of all these above mentioned drugs and diseases, we get few fungal infections in our body. Saprophytic fungi are easily invade the tissues due to their breakdown of host defense mechanism by the above agent. Because of the above drugs, our defense mechanism will be lost, and hence the growth of funguses increases in the body. Take small note on the history. The first drug to be discovered or introduced, the first antifungal, was amphotericin B in 1960. Then later, in the subsequent years, the different groups of drugs like flucytosine, imidazole, triazole, terbinafine were introduced, and the final drug that was introduced in 2001 are echinocandins. Echinocandins are the latest edition drugs that are introduced into the antifungal group. Coming to the classifications of systemically used antifungals. Okay. Now, there are four types: antibiotics, antimetabolites, which is shown in this page. Just let me subdivide the antibiotics. They are depending upon the structure present inside this chemical structure. It is divided into polyene antibiotics, echinocandins, and heterocyclic benzofuran. Under polyenes comes our first drug, that is amphotericin B. Under echinocandins, which was recently introduced into the antifungal group, includes caspofungin, micafungin, and heterocyclic benzofurans includes griseofulvin. They are the antibiotic antifungals. Coming to antimetabolite includes flucytosine. Coming to the classification, the rest includes azoles and allylamine. Under azoles, there are imidazoles and triazoles. Under imidazole, systemically we use ketoconazole, and triazoles include fluconazole, itraconazole, voriconazole, and posaconazole. Allylamine includes terbinafine. So, when we classify antifungals, they are divided into antibiotic antifungals. Then we studied about the what is that? Metabolites, antimetabolites, then azoles and allylamines. So this is the classification of antifungals. We will go in detail about each antifungal drug. The first one includes antibiotics. Under the antibiotic, the polyene group. Now, the polyene group is derived from highly double bond structure. The main drug under polyene derivative antibiotic includes amphotericin B. They are obtained from the streptomyces, Streptomyces nodosus. Okay. Now, when you look into the chemistry or the structure of the drug amphotericin B, it has a macrocyclic ring to one side having a conjugated double bonded structure, and on the other side it has an OH or hydrophilic. Okay, lipophilic one side and hydrophilic on the other side. No need to know in detail about the structure, but no, it has a macrophilic structure, a bigger size structure with the polyene group in that. Okay, with the hydrophilic and the hydrolipophilic structure. Now, coming to the mechanism of action, here polyenes. Okay, they have high affinity for the ergosterols present in the fungal cell membrane. Fungal cell membranes has steroidal structure called as ergosterol. They combine, that is the polyene structure of the polyene structure of our antifungal drug will combine with ergosterol, get inserted into the fungal cell membrane and produces small holes in it called micropore. Through the micropore, each content of the fungus starts leaking and the fungus dies off. This is what happens or this is the mechanism of action of antifungals. As I told you, there is a formation of micropores. Hydrophilic sites from the interior forms interior of the pore. Ions, amino acids, and other water-soluble substances will move out. On the outer surface, membrane sterols will fill up the space between the amphotericin B and increases permeability. And as a result, the fungus dies off. Coming to the spectrum of amphotericin B, they are active against wide range of yeast and fungus, which includes Candida albicans, Histoplasma, Cryptococcus neoformans, Blastomycosis, Coccidomycosis. Mostly all the antifungals. That is why wide range. They are fungicidal at a higher temperature and are static at lower temperature. Also, they are active against few species of Leishmaniasis, okay, or Leishmania. Coming to the PK or pharmacokinetics, amphotericin B cannot be absorbed. It's not absorbed orally. It is, but it is given for intestinal candidiasis. They usually administered IV as a suspension made with deoxycholate. Now you cannot administer amphotericin B orally, only IV, and that too if IV it should be mixed with inside a suspension known as deoxycholate. Now it is widely distributed in the body, but CSF penetration is very poor. So any brain abscess or brain infection, brain due to fungus cannot amphotericin B cannot be used because it has a very poor CSF penetration. Now it will bind to sterols in the tissues and lipoproteins in the plasma, and the T half is about 50 days. 60% is metabolized in the liver, excretion is slowly in the urine and bile. The dose. There is no need to know about the dose, but a small note about the dose. Orally, 50 to 100 microgram QID for intestinal candidiasis. Topically, it can be as amphotericin B ointments can be given for vaginitis and automycosis. Automycosis is nothing but infection of the ear. Conventional formulation of amphotericin B are used in for systemic mycosis, which includes intestinal candidiasis or any systemic involvement of fungus. Coming to liposomal amphotericin B. Liposomal amphotericin B is another targeted drug delivery system of amphotericin B. It will help in the improved tolerability of IV infusion of amphotericin B. Yeah, there are few side effects of amphotericin B which will be overcome by this preparation. It will reduce the toxicity and also it achieve a targeted delivery. Milder side effects, milder acute reaction on IV infusion, and also it is used in patients that are not tolerating our conventional amphotericin B preparation. Also, it will have lesser nephrotoxicity. So, few side effects as well as targeted drug delivery system can be achieved by liposomal amphotericin B. Coming to the uses of liposomal amphotericin B, they are used since they deliver into the reticuloendothelial cells in the liver and spleen. They can be used for Kala Azar and immunocompromised patients. Plus, I told you febrile neutropenia. Empirically, they can be given to patients who have developed febrile neutropenia, and also amphotericin B colloidal dispersion (ABCD) has the similar property of liposomal. Another delivery system which will be targeted towards the required cells. Coming to the uses of amphotericin B, topically it is used for oral, vaginal, and cutaneous candidiasis, and also it is a first line of choice for various systemic mycosis, which includes candidiasis, cryptococcus, histoplasmosis, coccidomycosis, and blastomycosis. Various others include sporotrichosis, aspergillosis, and mucormycosis, and also can be used for the treatment of febrile neutropenia. As I told you, it is active against few species of leishmaniasis. Leishmania, it is helpful in leishmaniasis also, more effective for resistant cases of Kala ulcer and mucocutaneous leishmaniasis. Now coming to the side effects, as I mentioned earlier, they have very what do you say common side, not common, very acute side effects which immediately is seen after infusion of these drugs. Uh, they can be divided into acute and chronic reactions. Under acute reactions, what you see is after the IV infusion, uh, Some patients will have chills, fever, aches, and pain all over the body. Some experiences nausea, vomiting, and dyspnea, which will last for 2 to 5 hours. This is due to the release of cytokines, that is interleukin and tumor necrosis factor alpha. To prevent such reaction, we usually give them a prior injection hydrocortisone, that is a steroid, to reduce intensity of the reaction. Thrombophlebitis of the injected vein may also occur and is also a common side effects noticed among these patients. Coming to the long-term toxicity, those patients who will have drugs taken for months will experience nephrotoxicity. That is one of the most important toxicity. Okay, they will present with azotemia, reduced GFR, acidosis, hypokalemia, and inability to urinate. Reverses slowly after the drug is stopped. This condition can be stopped when this condition on nephrotoxicity is reversible when the drug is being stopped. Also, some patients may experience anemia, that is also slowly progressing due to bone marrow depression. And the third important side effect on long-term toxicity is CNS toxicity. Usually on intrathecal injection, they experience headache, vomiting, and nerve palsies. Okay. When coming to the interaction under interaction, flucytosine, which is an anti-metabolite, just now I told you in the classification. When you combine flucytosine with amphotericin B, there will be super additive action because they become is very sensitive. Fungus becomes very sensitive to both, as amphotericin B will increase the penetration of fluorouracil of flucytosine into the fungus. Aminoglycosid, vancomycin, cyclosporin, and other nephrotoxic drugs will enhance the renal impairment caused by AMB, that is amphotericin B. So, whenever you prescribe amphotericin B, just check whether other nephrotoxic drugs are not prescribed along with this drug. Coming to the next group, that is azoles. Under azoles, there is imidazoles and triazoles, and now they are presently these groups of drugs are the presently most widely used or extensively used antifungals. They have a broad spectrum, including dermatophytes, candida, and other deep mycosis, except mucormycosis. They can also have action on nocardia and leishmania. Now coming to the mechanism of action of azoles. The azoles, triazoles as well as imidazoles, both inhibit the fungal cytochrome P450, specifically the lanosterol 14 demethylase. Now this impairment will cause ergosterol synthesis, leading to a cascade of fungal membrane abnormalities. That is, the fungal membrane will be abnormal, or the stability of the fungal membrane will be lost, and hence there is leakage through the fungal membrane and the fungus will die off. Or else mutation of the gene of 14 demethylase underlies azole resistance. Now this mutation can cause azole resistance. So these drugs are prone to be resistance also, to cause resistance also. Coming to the first drug, ketoconazole. Now coming to ketoconazole, this is the first orally effective broad-spectrum antibiotic. Now, including the pharmacokinetics, the oral absorption of ketoconazole is increased by gastric acidity and more soluble at lower pH. Hepatic metabolism, they undergo metabolism in the liver. Metabolites are excreted out in urine and fecal matter. The T-half varies over here from 90 minutes to 6 hours. The T-half may be 90 minutes, some may have between 90 minutes to 6 hours. Here also the CSF property or penetration is very low, so not effective in fungal meningitis. The dose is 200 milligram OD or PD. Coming to the side effects of ketoconazole, and when you compare it with amphotericin B has more side effects when compared to ketoconazole. The most common side effects here is nausea and vomiting, as you all write for many of the drugs, nausea and vomiting. Plus, it will have loss of appetite, headache, paresthesias with rashes and hair loss. Some patients will also experience decreased androgen production from testes and displaces testosterone from its binding sites. This will lead to they go into loss of libido, oligospermia, and gynecomastia. In females, there will be abnormal menstrual cycles due to suppression of estradiol synthesis, and this is contraindicated in pregnant and lactating women. Coming to the interactions of azoles, here H2 blockers, proton pump inhibitors and antacid will decrease the oral absorption of ketoconazole by reducing the gastric acidity. In the first line, I told you gastric acidity will increase absorption. So these drugs which decreases gastric acidity will decrease the absorption of ketoconazole. Rifampicin, phenobarbital, and carbamazepines plus phenytoin will induce, since they are enzyme inducers, will induce the ketoconazole metabolism and reduces its efficacy. The action of ketoconazole will be lost, and also ketoconazole inhibits cytochrome 3A4, 2C9 and 2C19, and increases the level of phenytoin, digoxin, omeprazole, warfarin, nifedipine, and diazepam. So, few interactions should be known about ketoconazole. Gastric acidity decreasing drugs will decrease absorption, plus inducers will decrease the efficacy, and ketoconazole itself can inhibit few metabolism of few certain drugs and increase the toxic level. Coming to the uses, oral ketoconazole are very effective in dermatophytosis. Also, the lotion and shampoo preparations are very effective in seborrhea of the scalp and dandruff. Recurrent or resistant monilial vaginitis, plus systemic mycosis, which includes oral ketoconazole, but triazoles are preferred, not imidazoles but triazoles. Occasionally, they are used in dermal leishmaniasis. Also, very high dose of ketoconazole are used in Cushing syndrome to decrease the corticosteroid levels. So, these are the few uses of ketoconazole or imidazole group. Coming to fluconazole. Fluconazole is a water-soluble triazole with a wider range of activity when compared to ketoconazole. 94% of the fluconazole are absorbed orally, and oral bioavailability is unaffected by food, whereas ketoconazole is affected by food. Okay, they are excreted unchanged through urine. The T half is about 25 to 30 hours. Now, fungicidal concentration is achieved in the nail, vagina, and saliva. So, they are usually given for any nail infection, fungal infection of the nail. It has a very good CSF penetration, so it is very useful in fungal meningitis. Also, dose reduction is required in renal impairment patient as it is excreted out through urine. Coming to the uses of fluconazole. First one, vaginal candidiasis, oropharyngeal candidiasis, candidal esophagitis. Then coming to tinea infections and cutaneous candidiasis, which where you should give at least the drug for 4 weeks, plus disseminated candidiasis. The dosage for is not very important for you at this stage, but know what are the uses of fluconazole. The other uses of fluconazole include long-term maintenance therapy after initial IV amphotericin B or fluconazole used in AIDS patient with fungal meningitis. So, if AIDS patient with fungal meningitis will require long-term therapy of fluconazole on the maintenance base. Again, fungal keratitis, it is used for fungal keratitis. Eye drops of fluconazole is used. Ineffective in aspergillosis and mucormycosis. Two other systemic conditions where fluconazole is very ineffective is aspergillosis and mucormycosis. Coming to the adverse effects of fluconazole, very fewer side effects when compared to ketoconazole and amphotericin B. Nausea, vomiting, abdominal pain, rashes, and headache, which is very common to all the drugs, are also present here. The incidence will increase with dosage and duration of the therapy. Plus, selectivity for fungal cytochrome P450 thus does not inhibit steroid synthesis in human. Selective, it is very selective of fungal P450, not for human P450, so it does not affect the humans. Some may experience elevation of hepatic transaminase, that too in AIDS patient. Not recommended in pregnant and lactating mothers. Coming to the interactions, it will increase the plasma level of phenytoin, acetaminophen, cisapride, cyclosporin, warfarin, azidovodine, and sulfonylureas. I hope you know each individual drug where it stands for, what it is being given for. So, whenever we give fluconazole along with these drugs, the level of the respective drugs will increase. In case of fluconazole, is the what do you say, combining drug, and also few cases of ventricular tachyarrhythmias are also seen seen when given with cisapride. Plus, proton pump inhibitors and HO blockers do not affect its absorption, which is seen with ketoconazole. Coming to itraconazole, itraconazole is another orally active triazole with a broader spectrum of activity. They are active against aspergillosis and fluconazole resistant candidiasis. After we give fluconazole, some may not respond to the fluconazole. So, such fluconazole resistant candidiasis, we can give itraconazole. They are fungistatic, even more effective in immunocompromised patients. The oral absorption is variable but enhanced by food, highly plasma brown bound, and has a larger volume of distribution. They get accumulated in the vaginal mucosa, skin, and the nails, as seen with fluconazole. Their availability or crossing blood-brain barrier is very poor, or the penetration to the CSF is very poor, so not very effective in fungal meningitis. Metabolized by this liver by secret cytochrome 3A4, an active metabolite is excreted out through the fecal matter. The half-life is about 30 to 64 hours. The adverse effects includes, if the dose is 400 milligram per day. Per day, if you give more than 400, they'll have gastric intolerance, dizziness, pruritus, headache, and hypokalemia are very common. Rise in plasma transferase or transaminase, or there is a derangement in the LFT value, plus impaired left ventricular function is also seen in some cases. Coming to the interactions of itraconazole, oral absorption of itraconazole is reduced by antacids and PPA. So, PPA and antacids should not be combined with itraconazole. Their absorption will be decreased. Rifampicin, phenobarbital, phenytoin, carbamazepines will induce the metabolism, and the efficacy will be reduced as they are enzyme inducers. Clarithromycin and protease inhibitors will reduce the metabolism, and their level will increase in the blood. Inhibit cytochrome 3A4. So, drug interaction similar to ketoconazole. Ventricular arrhythmias with cisapride and terfenadine are seen, plus estimazole. All these will produce ventricular arrhythmias. The uses of itraconazole when compared, azole fungals are usually antifungals are usually preferred for histoplasmosis and blastomycosis. This is a drug of choice for paracoccydomycosis and chromomycosis. It has it can bring relief to aspergillosis, where fluconazole does not act against aspergillosis. Otherwise, it can be given for vaginal candidiasis, dermatophytosis, and onychomycosis. Voriconazole, another second generation broad spectrum triazole, where it uses an invasive aspergillosis, disseminated infection by fluconazole resistant candida, fusarium infections. Febrile neutropenia are responsive to antibacterial therapy, and also it is caused serious cases first treated by IV, then followed by oral uh, preparations. That is, any serious cases of fungal infection will be treated with first with IV and then with oral tablets. So when we discover more and more, or find out more and more new drugs in the group, it shows whatever side effects are what you say, whatever inability it had with the first drug, that is either the side effects or the absorption property, all those will be corrected with the newer drugs. Okay, here see again broader spectrum used in fluconazole resistant candidiasis. Also, those who do not respond to antibacterial therapy for febrile neutropenia, this can be also used. And it is completely absorbed orally except when taken with fatty meal. Metabolized by cytochrome enzymes and excreted in urine. It interaction as it metabolized by cytochrome B50. It has similar action to ketoconazole interactions. Other side effects will be rashes, visual disturbances, QT prolongation. This is a newly introduced drug into the broad spectrum triazole, posaconazole. No need to know much, but you should know that it is very effective at mucormycosis, and also reserved for non-responsive cases of aspergillosis and candidiasis, febrile neutropenia, and prophylactic in immunosuppressed, plus chromomycosis. The adverse effects of posaconazole includes nausea, abdominal pain, loose stools, headache. Others includes anemia, neutropenia, cardiac arrhythmia. These are very rare. Now, oral suspensions are better absorbed in a lower pH and can increase drug metabolism. In these, drug can increase drug metabolized by cytochrome 3A4.